All right, let's talk about one of the most difficult, most frustrating challenges we face as surgeons, the high output enterocutaneous fistula. You know the ones. These cases test everything: our resources, our teams, and honestly, our patience. Today, we're going to dive into an approach that goes way beyond the traditional playbook, one that actually uses the patient's own body to help us win these tough fights. So here's our game plan. First, we'll set the stage. Just how big is this problem? Then we'll look at the old way versus a much smarter, more physiological way. After that, we'll get into the nuts and bolts, the how-to. Then comes the proof. We'll look at the clinical evidence. And we'll wrap it all up with the key takeaways you can bring right back to your practice. So let's start by really defining the enemy here. Because before we can talk about the solution, we have to have a crystal clear understanding of just how serious this challenge really is. Let's just start with a number that should get everyone's attention. The literature is pretty clear that for some of these fistulas, especially the really complex duodenal ones, the mortality rate can climb as high as 40%. This isn't just a complication, you know? It's a full-blown, life-threatening crisis that absolutely screams for a better way to manage it. And then you've got the worst of the worst, the enteroatmospheric fistula, or EAF. I mean, this is a whole other level. We're not just talking about a little track to the skin. Here, the bowel is literally open to the world inside a gaping abdominal wound. It's the absolute nightmare scenario. You've got insane fluid loss, combined with a massive risk of sepsis. And this thing just kicks off a devastating downward spiral. You get these huge fluid and electrolyte shifts. The patient goes into this severe catabolic state. They're literally wasting away. All this is happening while you're fighting off sepsis and dealing with what is, for all intents and purposes, intestinal failure. These patients end up becoming long-term residents in the ICU, and breaking that cycle is just incredibly tough. Okay, so for decades, our main weapon in this fight has been parenteral nutrition. But it's about time we stepped back and asked, can we do better? Can we work with the gut instead of just bypassing it? That's what this is all about. Look, there's no doubt about it. PN saves lives. It gets calories in and lets the bowel rest. We all know that. But when you're talking about managing these complex fistula patients for weeks or even months, is it really the best we can do? Or is it just the default setting we've all gotten used to? And this is where it gets really interesting when you put them side by side. On the one hand, with PN, we just accept a ton of risks, right? Line sepsis, the high cost, the complexity, and the big ones, intestinal atrophy and liver problems from not using the gut. Reinfusion, on the other hand, flips the script. It uses the patient's own digestive juices, it keeps the gut healthy, and it gets things back to a much more normal physiological state. And hey, this isn't just a cool idea. The data is there to back it up. I mean, this quote from Flug and his colleagues says it all. We have known, fundamentally, that using the gut is better whenever we possibly can. The real trick has always been figuring out how to do it when you've got a high-output fistula staring you in the face. Okay, so it's one thing to talk about physiology in a presentation, but it's a whole different ballgame to actually make it happen at the bedside. So let's shift gears and get into the practical side of this. How do we actually do it? The whole process really boils down to 4 main steps. Step 1, and this is non-negotiable, you have to get sepsis under control. Don't even think about starting this on a patient who's actively septic. Once they're stable, you start collecting the chyme from the upstream opening. Then you reinfuse that chyme, often mixed with some enteral formula, into the downstream limb. That's what we call fistuloclasis. And all the while, you are watching them like a hawk. Their tolerance, their fluids, their electrolytes. Now, how do you actually get it in there? Well, you've got options. A bolus feed is the simplest, but it can be hard for the patient to handle that much volume at once. A gravity drip is usually tolerated much better, and you don't need a pump. And then there's the pump, which gives you the most control and mimics normal physiology the best. But you're going to need more gear, and you have to watch out for the tubing getting clogged up with junk from the chyme. And you know, we shouldn't overthink the equipment. I love this little story from one of the case reports where a nurse came up with this really effective gravity feed system using just a simple enema bag. It's a fantastic reminder that success here comes from the whole team being creative and working together. All right, so we've covered the why and the how. But now we get to the part that really matters, the results. Does this stuff actually work? Let's look at what the evidence shows. Let's make this real. Let's talk about a case from the literature. A 42-year-old woman, she's had multiple surgeries, she's got several high-output fistulas, and she is just getting hammered by complications from long-term PN. We're talking recurrent septic shock, hypokalemia, a classic, really tough case that we've all seen. And just look at the turnaround here. After about 2 months of chyme reinfusion, The numbers speak for themselves. Her albumin goes from a dismal 2.0 up to a much healthier 3.5. Her weight stabilizes and even starts to climb. And clinically, she's like a different person. No more sepsis, her edema is gone, and she gets to a point where she's actually optimized enough for a definitive operation. It's incredible. And here's the kicker. This wasn't just about her looking and feeling better. They had objective proof. Radiographic studies actually showed that her small bowel was increasing in caliber and length. This is hard evidence that we are actively reversing that intestinal atrophy we talked about. We're actually rehabilitating the gut. Now, we have to be realistic here. This is not some magic bullet. It's not a set it and forget it kind of thing. It can be hard. Patients might not tolerate the volume. The tubes will clog. It takes a huge amount of education for the patient and their family. You can only pull this off with a really dedicated, top-notch multidisciplinary team. Okay, so let's boil this all down. What are the key things to remember? What are the actionable principles you can take away from this? Here are the 6 big ones. Number 1, control sepsis first, always. 2, use the patient's own chyme. It's the best digestive fluid there is, period. 3, think of this as a bridge to get your patient strong enough for the final surgery. 4, the whole point is to get them off PNN and avoid its complications. 5, be flexible. Pick the administration method that works for your patient. And finally, number 6, you cannot do this by yourself. This is a team sport. So when you look at all the evidence, it's pretty compelling. This physiological approach gives us a real path to stabilize our patients, to build them back up nutritionally, and to save people that we have really struggled with for a long time. Yeah, it takes effort and expertise, but the upside is huge. So the question we really need to ask ourselves is, shouldn't this be our new standard of care?